we did medicine to cure. And hematology is probably one of the most fascinating specialties because it combines biology and clinic. And most of the developments in oncology can start in hematology. And I would recommend, this is my final message, to many of the students of medicine to become hematologists because this is a fascinating specialty. And EHA is doing a lot just to make this specialty one of the best opportunities for all of us.
So welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera, and today's guest is Professor Jesús San-Miguel. Professor Jesús San-Miguel is a professor of medicine hematology and currently senior consultant at the Cancer Center of Clínica Universidad de Navarra in Spain. He has devoted his life to improving the diagnosis, treatment, and monitoring of multiple myeloma patients. With over 1,000 publications, he has shaped modern myeloma research and treatment. He is the recipient at this EHA 2025 Congress of the EHA Lifetime Achievement Award. So congratulations, Professor San-Miguel.
Thank you very much, and thanks for the opportunity to be here with you today.
Welcome to this podcast. So in this podcast, we're going to be discussing first, review your trajectory and see how your key scientific discoveries connect with the advancements of the field. And then we want to have a little look at how the multiple myeloma field is now and what are the treatments available and what are, in your opinion, the future directions of the field. So to start on your trajectory, can you tell us about what inspired you to work on multiple myeloma?
If you allowed me to go back in my trajectory,
Yes,
I would say that I was not planning to be a doctor. This has happened many times in my life. Plans has changed. I was planning to be an architect, although I have not a spatial visual. But my father was a vet, and he constantly repeated to me, medicine is the most beautiful profession. One day, another day. Then I decided, okay, let's stop him to talk to me about this. I will do medicine. This was the first. Second is why I became hematologist.
okay.
Then I will come why I became interested in multiple myeloma.
Yes.
But before,
Yes.
why I became hematologist. I was doing my studies at the University of Navarra, and I was just waiting for the last exam. The last exam was a general exam on medicine, and there was one professor that examined you about this. And this, curiously, was the professor of hematology, Professor Borrasca. I was waiting in front of his door, and a resident, that now then become very good friend, a resident of hematology, just crossed. And he asked me, what are you doing here? Waiting for the exam with your boss. And he said to me, he's going to ask you about paroxysmal nocturnal hemoglobinuria. What is this? I never heard about that. No, we have seen the first case in our institution. And this is hemolytic anemia with the urine is very dark, similar to Coke, and blah, blah. Okay. I went into the exam. Professor Borrasca started to ask me about how to treat acute renal failure, diabetes type 1, other questions. And he said, okay, very good. But if you want to get the maximum score in the exam, you need to answer me this question. What do you know about paroxysmal nocturnal hemoglobinuria? The resident told me that the name was PNH. Okay, I said, please, can you repeat? Can you repeat the question? Yes. What do you know about paroxysmal nocturnal hemoglobinuria? I said, I'm not sure. I think the name is, they also call HPN? No, PNH. Oh, yes, sorry, PNH. I'm not sure. I think it's hemolytic anemia that the urine due to acidosis is very dark in the morning, similar to Coke. I say, what are you planning for the future? What do you want to be? I say, I was thinking in endocrinology, cardiology. No, you will become hematologist. I say, no, I'm not planning to do him. No, there is no discussion. You will become a hematologist. And you will move with me next week to Salamanca. I have just got the chair in Salamanca, and you will move with me to build up the hematology department there. And you will come now with me to see the first patient we have seen with this disease. Brilliant. I didn't say anything. Then later on, I explained to him that was just by chance that I know it. But chances sometimes change your life. And in fact, this was my case. And something similar, why I become interested in myeloma. I was a resident in Salamanca with him. We were building up the hematology department. Until that time, there was not hematology department. There was only biology, not clinic. And I asked him, Professor, I want to do a PhD thesis. He was a clotter, okay? He was mainly interested in hemostasia. And most of the PhD thesis students there were doing the thesis on hemostasia. And he said, I have just read a paper on multiple myeloma and subclasses of immunoglobulin. Why you don't do it in this topic?
Okay.
I say, but nobody is doing that here in the department. Someone should start to do it. And this was the reason why I started to be engaged with multiple myeloma. As you can see, life drives you to different corridors. And the only thing that you need is to follow the right corridor and to be enthusiastic in your work.
Once you get into it and you become really good at it, then it becomes really something that you really enjoy doing.
Paul Sartre used to say that life does not consist in doing what you like, but liking what you do.
Liking what you do, exactly.
And this is definitely.
You're a perfect example of that. Can you also take us back of what was the management then of multiple myeloma patients at the time?
I can also make another confession. As I mentioned, at our department, the most brilliant people were dedicated to hemostasia and thrombosis, and also to malignant hematology, but mainly acute leukemia and lymphoma. Nobody was interested in multiple myeloma. And the reason was very simple. Myeloma was an incurable disease, only one drug, melphalan. How we treat the patients with melphalan, continuous melphalan. We stop at some time melphalan. We reintroduce again melphalan. There was nothing else. Melphalan and corticosteroids. The median survival of myeloma patient was around 2 years. Miserable disease with acute renal failure, with chronic renal failure, with bone disease, fractures, devastating disease. And this was in the early 90s. Then the autologous transplant came on and changed quite a bit the outcome of myeloma patients. But it was also based on the same drug, the melphalan. There was no other drugs really efficient for myeloma treatment at that time.
So you have been instrumental in the development of 5 drug combinations for multiple myeloma. What can you tell us about how this came in time and how they changed the management of multiple myeloma?
Okay. I will never forget when we start to work with bortezomib. But just before that, thalidomide has emerged in the market as an active drug for myeloma. At that time, thalidomide was out of the market. As you know, it was responsible for all these childbirth problems, and it was only used for leprosy. But due to angiogenesis, it was discovered that the capacity of anti-angiogenic role of thalidomide, and this clearly changed the field of myeloma. This was the first immunomodulatory drug. Immediately, almost in parallel, a proteasome inhibitor, bortezomib, that started to be called PSC341, was discovered, and we were very lucky just to participate in the early clinical trials in relapse patients. But probably one of the most challenging situations when we decided to combine bortezomib with melphalan in newly diagnosed patients, non-transplant candidates. And for the first time, we saw that this combination was able to induce complete response outside of the transplant. Until that moment, only the transplanted patients were able to eradicate the paraprotein, but with a combination of bortezomib and melphalan-prednisone, 30% of the patients achieved complete response. But we paid a tribute for that because peripheral neuropathy was a side effect that was unexpected at the beginning and complicated the life of the patients. But we learned how to handle this, moving from twice weekly to only once a week, bortezomib, by reducing also the dose, and now the proteasome inhibitors is part of the treatment, of the skeleton of the treatment of myeloma patients, together with immunomodulatory drugs and the corticosteroids. This was, for me, one of the most amazing situation. Then we will be part also of other drugs, particularly with pomalidomide, to have pomalidomide being approved in multiple myeloma for late relapses and then for early relapses. And probably the most recent one is the CAR-T stories. Using CAR-Ts, particularly one of the CAR-Ts cell in late lines of therapy, patients that have no other options at that time, after 5-7 lines of therapy, the expected median survival for those patients was 5-8 months survival. And now the report is that 5 years after initial treatment, 1/3 of the patients are progression-free. Mm-hmm. Can you imagine?
Yes.
30%, 33% of the patients, 5 years progression-free in a situation that they have no options. And we have also the conjugated antibodies, lantamab. We have the bispecific antibodies, several, istamab, linvolcetamab, elranatamab, several. And we have the opportunity to target 2 antigens now. I mean, the field is moving.
Yes.
The field is changing.
Mm-hmm. All of these treatments target BCMA?
This is funny because one of my first presentation at us on immunophenotyping was on the expression of CD10 in multiple myeloma and CD19 and CD20, because until that time, we consider that the plasma cell was antigenically silent, no expression of antigens. But we saw that there was some antigens, and this was key for minimal residual disease studies. Mm-hmm. Okay? And now we know that the plasma cell expresses several antigens that are really very important for the treatment that you choose. We have the CD38 antigen, we have the BCMA, we have the GPRC5D, but we have also CD19, we have also FcRH5, we have many antigens, and we have drugs that target individually this antigen or can target 2 or 3 antigens. Then this is the future from my point of view.
Mm. So you mentioned MRD. So MRD is measurable residual disease. You have also pioneered the use of this tool to better diagnose and treat patients. What can you tell us about how important MRD is and how it's being used?
Yesterday, a colleague reminded me that the first patient I published about the potential use of MRD was in 1994. But the first real paper was in 2002, 22 years ago. And in that paper, we reported the analysis on patients that were in morphological complete response. They had less than 5% plasma cells in the bone marrow, but we didn't know if these plasma cells were normal or abnormal. And by flow cytometry, we demonstrated that if the cells had antigenically an abnormal pattern, these were residual clonal cells, and these patients, although they were in complete remission, had significantly lower survival than the patients that were MRD, we call minimal residual disease negative. Then we move also to ASO-PCR molecular technique, and we demonstrate the same. We demonstrate that under the cutoff of morphological remission, you have still many residual cells. And if you want to cure a disease, you need to eradicate the cells, and you need to use the best tools to evaluate the residual disease. This is something that is very easy to understand. In solid tumors, a surgeon that is dealing with a breast cancer, before he finishes the surgery, he asks the pathologist, how are the borders, the margin, are clean? And if they say no, he continues the surgery until he gets rid of any tumor cell in the margins, in the borders. The same occurs in hematology and in multiple myeloma. That is our case. If you have residual cells, this means that this patient is going to relapse. Then we need to eradicate all the residual cells, and we need to work for that. The good news is that last April, we presented in front of the ODAC of FDA the result of a huge study, including 12,000 patients coming from randomized trials from a consortium between academic center and the industry working together. This analysis was able to show that the patients that achieve MRD negativity in the transplant setting, in the non-transplant setting, and at relapse, enjoy significantly longer progression-free survival and overall survival. And based on these results, the ODAC, the FDA, approved minimal residual disease as a new endpoint for trial approval, for drug approval. Is this important? Extremely relevant. I always make the same example. We are conducting now, participating in a clinical trial in which CAR-T newly diagnosed patient is being compared with autologous transplant. The readout in terms of progression-free survival of this trial will take 10, 20, 15 years. Then we will not know if CAR-T should be implemented in first line until 15 years from now. But the readout from minimal residual disease will take only 1 or 2 years. And if the FDA considers that this is a valid endpoint, then we will have the opportunity to use the new drugs much early on.
And now MRD is being done also on circulating
plasma cells.
Not necessarily in bone marrow biopsy. So it's becoming easier to follow during time.
Yeah,
no?
Much easier. We try to spare the time in between the bone marrow exams, and in the middle, we use the circulating tumor cells or the mass spectrometry, both techniques.
So all of these developments have been thanks to big collaborations, as you've just mentioned. How can you give us an idea of how important it is that people collaborate across the field to bring these results to the patients quicker?
I think there are 2 days in our life that are critical. One is the day you are born. And the second is the day that you know for what had you been born. Better, for whom had you been born? And if you are a doctor, you had been born to help the patients. But if you want to help the patients, first you want to help your colleagues. Because a team is not a group of people that work together. It's a group of people that trust each other and is able to help the others. For me, this is the most important part of my work philosophy, to try to build up a good teamwork, making the people happy in the work. And when I say this, I have the fortune to be working with very brilliant people that now they are leaders in the field, extremely well recognized. Some of them are also head of the department, the important departments in Spain. But together with them, there has been a lot of anonymous hematologists, not in the podium, but they have worked very hard to consolidate the teamwork and to help the others. And when I see these people that they are proud of the others that are in the podium, I always think the same. Are the people in the podium also proud of these people that is doing general hematology? And I can tell you, usually the answer is yes. And for this reason, people can be together and can get the best of each other. What I think is the final goal of a head of the department, just to try the best of each one and to help them to spend 8, 10, 12 hours in the work, being happy and going home happy. Because it's a disaster if you are not happy in the many hours that you spend in your work. For this reason, I think it's critical, and we need to educate the new leaders not to think that at the end of the career, they will be judged for the papers that they have published. This is rubbish. They will be judged for the people that they have helped to grow and to be happy in the work. And this is what I feel, is what I think. I'm not sure if I am correct or wrong, but I feel more and more that this should be the commitment of the leaders in hematology.
So the new EHA guidelines on multiple myeloma are being presented now at this Congress. What is new in these guidelines that you would like to highlight?
Okay. I think always when we create new guidelines, we think in all the hematologists. Sometimes the guidelines can be oriented to the groups that are leader groups in the field that have opportunity to use all the drugs, but in the guidelines it's also very important to think about those centers that have not access to so many fancy drugs. And this is very important because there are many, many centers, many, many countries, emerging countries with economical constraints, and you need to demonstrate in the guidelines also that some of the triplet combination are efficient, not so efficient as the quadruplet, and I think is one of the goals of the guidelines. Also in the guidelines, we have not talked about the early disease intervention, early detection because of time constraint, but it's, I think, also one of the most important fields that we should move on to treat early on myeloma, as we do with the solid tumors.
So as you look back into your career, what brings you most hope now for the patients? And what do you see coming that is really promising?
Okay. As you probably have seen through this interview, I'm a bit sentimental. Progress in myeloma has been enormous. We expect a progression-free survival with a quadruplet plus transplant of more than 15 years. Outside of the transplant, the progression-free survival with first line is going to be more than 10 years. But still, there are patients with very high-risk disease that we need to improve. And in any case, what the patient needs is that the doctors understand what are their feelings, what are their needs, because there are patients that want to fight for any treatment that is able to eradicate the disease. Other patients need just to control the disease and to avoid as much as possible the continuous visit to the hospital. You should sit in the other side of the table frequently to know what the patient desires are in order just to give him the best possible solution. And I always try to finish my consultation with the patient saying the same words, probably a bit repetitive. Could I do something else for you?
So what do you want to add for the audience that I have not asked you?
This is a fascinating specialty. And EHA is doing a lot just to make this specialty one of the best opportunities for all of us.
Thank you very much for being our guest today. It's been a pleasure going through your career with you, Professor San-Miguel. Thank you to our audience, and please stay tuned.
Thank you very much. It has been my pleasure.